and my colleagues about evaluation of ptosis. As we all know, ptosis is drooping of the upper eyelid, which could be congenital or acquired being further classified as myogenic, neurogenic, aponeurotic, or mechanical. And we call the ptosis as congenital and complicated if it is associated with blepharophimosis syndrome, with double elevator palsy, superior rectus weakness, or a synkinetic ptosis. Now, these are the few famous personality who do have ptosis, but we rarely notice it, like Ranveer has this, left eye mild ptosis. John Abraham has a right eye inverse ptosis. And this famous prodigy of Indian cinema, Lalita Pawar, who had a left eye traumatic ptosis during a shoot. When she was slapped, she developed a ptosis after a few days. Now, why we need to evaluate carefully? So as to avoid all these complications, a careful evaluation is very important. So our goal of evaluation should be, we should come to a point to know that what is the type of ptosis, whether it's a unilateral or bilateral, so as to plan the surgical decision and rule out any contraindication for surgery as well as any necessary modification of surgery. No evaluation is complete without proper history or examination along with few investigation to determine the choice of surgery. In history, age of onset is the most important, whether it's a congenital or acquired. Progression has to be looked, diurnal variation as in cases of myasthenia, and change with jaw movement has to be noted like in cases of Marcus-Gunn jaw winking. Family history is important, especially in cases with BPES or myotonic dystrophy. Now, first and foremost in examination, we have to rule out pseudotosis, as in this case where you can see there is appears to be a left eye ptosis, but on fixing with the left eye, the ptosis disappears, indicating that it's a pseudotosis. Now, ptosis workup has to be done under these following 15 heads. We'll come one by one in each and briefly point out what is the importance of each one. Visual acuity is important because most of the ptosis patient, because of the weight of the lid, will have an anisometropic amblyopia. Stimulus deprivation amblyopia is seen in unilateral severe cases, and amblyopia is quite rare in bilateral cases where they develop a chin up position. Pupil examination is important, especially in cases with Horner syndrome and third nerve palsy. Head posture, as already mentioned, in cases of bilateral severe ptosis, we will have a chin lift position. Frontalis overaction has to be noted, like in this case with the left eye, frontalis overaction. Now, coming on to the lid fold and lid crease are very important. Lid fold has to be dynamic at the end of surgery. So, always we take a bite through the LPS term while completing our ptosis surgery. And the lid crease has to be looked carefully so as to decide the surgical incision site. If multiple, then most prominent one should be considered and always should be matched with the contralateral side. Amount of ptosis, as we all know, margin reflex distance, which gives the severity of ptosis. Now, LPS excursion is the distance that the eyelid moves in millimeter from maximum down gaze to a maximum up gaze without elevation of eyebrow. So, this is how we check for the LPS action from maximum down gaze to maximum up gaze, and we measure it. In children, sometimes it is difficult to do this assessment, so a crude eye lift test is, gives a good indication of how much is the LPS action. Now, coming on to the vertical tarsal height. Vertical tarsal height is very important, especially if you are planning for a fascicular served surgery, where at least 8 millimeter of vertical tarsal height is mandatory before doing a surgery. Lid lag has to be noted, like in cases of congenital ptosis. Bell's phenomenon, it plays an important part in corneal lubrication. It should be graded as good, fair, or poor, depending upon the cornea visible on forcefully closing the eyelid. It is rarely reverse in cases where the eyeball moves upward and inward, and could be inverse, like in this case where eyeball moves downward and inward. This is also a kind of fair to good Bell's, and we can operate in such cases also. So this is how we check for Bell's phenomenon. Marcus-Gunn jaw winking. Marcus-Gunn jaw winking could be of various types. Like in this case, there is a mild jaw wink which is up to 2 millimeter. In few cases, it could be moderate jaw winking, like in this case where the excursion of the lid around 2 to 5 millimeter, and very rarely it will be severe like this. In 4 to 6% cases, we can have something like this, which is a bilateral Marcus-Gunn jaw winking. As you can see in this case, both the eyelids are moving, and very rarely it could be inverse, wherein when you open the mouth, there will be drooping of the eye instead of winking. So, coming on to the next point, that is ocular movement, very important, especially to rule out third nerve palsy and superior rectus underactions. Corneal sensation, as we checked with the cotton vest, the tear film breakup time and a Sherman test has to be done, and no examination is complete without old photographs. Okay, so this is also very important. We always ask for the old photographs to the patient. Now, I'll just briefly mention few special forms, like congenital ptosis, where there will be lid lag on down gaze. Superior rectus or double elevator palsy has to be treated carefully. In blepharophimosis syndrome, ask for a family history always in these cases. Marcus-Gunn phenomena, which I already mentioned. Secondary acquired ptosis, especially something like an involutional disinsertion or dehiscence of a LPS action. Senile ptosis, as we all know, there will be a higher lead crease compared to the other eye. Aponeurotic ptosis, in this case, as you can see, this is a case with a blepharochalasis where you have aponeurotic dehiscence of LPS and there will be thinning of LPS. Post-traumatic ptosis like disinsertion or trauma to the muscle belly, and mechanical ptosis in mass lesions, and myogenic ptosis in cases where we need to give a crutch glasses, and these are pseudoptosis like because of the anophthalmic socket and all. So that's how we should evaluate each and every case of ptosis. Thank you. Thanks a lot.